Today we shall be reviewing a case of a stent-assisted coiling of a ruptured anterior communicating artery aneurysm. This is the case of a 55 years old male patient, hypertensive, who presented to our hospital with a fissure grade 3 subarachnoid hemorrhage. There was massive hemorrhage intracranially on the CT scan, and the GCS was 13 out of 15. He was slightly drowsy, although there were no focal deficits. A diagnostic DSA showed a ruptured small anterior communicating artery aneurysm, which was filling from the left internal carotid artery injection. While doing the 3D angiogram, the aneurysm ruptured and free egress of contrast was noted from this aneurysm. This is the 3D image. The aneurysm we can see is quite small, and we can also see the contrast leakage demonstrated beautifully on this VRT image. The patient was resuscitated, intubated, kept in the ICU. His GCS gradually improved, and then, after discussion with family, he was taken up for endovascular embolization of the aneurysm. The left ICA was catheterized. A Ceribas 6 French guide sheath was taken up between the ICA, and the angiogram of the internal carotid artery was surprising because now we could see a full-blown aneurysm like large pouch. So it measured about 5 millimeter in size. However, we know that the aneurysm was quite small, and whatever we see now is actually a pseudo-aneurysm. It is very deceptive. It is not a true aneurysm. And had we seen it in the first time, we would have thought that it is aneurysm. We would have done a simple coiling because the neck looks quite small in this, and would have just gotten away, and the patient, and there would have been again a rupture. So we already have rupture of the aneurysm twice, and we would have had a third one, which would have been very catastrophic. So we decided to take a braided stent up. So we microcatheterized first the left ACA, and then we took another microcatheter and accessed the aneurysm. Then using a shelving technique of this braided stent, which was Elvis Evo from Microvention, we coiled the sac. Here we can see some loose coiling. For further down, we also have more packing of the aneurysm or the pseudoaneurysm, whatever we can call. This is the final deployment of the stent. The stent was pushed into the neck to give some compaction, create some flow diversion, and form a good shelf. My standard practice is to have eccentric measurement of the two arms of the stent. That is, one limb will be longer, one will be shorter. Uh, there's no particular reason, but I found that the deployment is easier and there are no complications this way. So we did the coiling and stent deployment, and we had a good angiographic result. Surprisingly, the right ACA was no more filling because we had compacted the stent and it had created a flow diversion effect. Then we took the right internal carotid artery injection, and we could see that the right ACA was territory was adequately perfused by the right A1 ACA. So the patient did well overall. After a few days, he was discharged from the hospital. There were no deficits. He had a small hemorrhage in the left middle cerebral artery territory from the start, and that had persisted. It was not a new one, and the patient continues to do well. Now we have a 6 months follow-up of this patient, and he's very recently, and that is why I thought of publishing this case. So the stent actually was extra compacted at the neck, which caused the flow diversion effect. And this is a good technique if we don't have a proper diverter stent because of cost reasons or sizing issues or anything. And this is essential in these kind of blister type of aneurysm. So this is a proper aneurysm. This was not a blister, which is erroneously called by a lot of operators, and this tight compaction of the cells of the braided stent work partially to create a flow diversion effect. In this particular case, there was good flow diversion because we could also see that the right A1 was not uh, had taken over the supply of the right ACA. So, one interesting thing I would like to tell here is that whenever we do this acute situation stent assisted coiling in ruptured aneurysms, we do not load with antiplatelet. We give intraprocedural tirofiban and then continue the infusion intravenous for next 20 hours. During this period, we load the patient with ticagrelor and aspirin and then continue with oral dual antiplatelet for 3 months. And if the patient doesn't have any atherosclerotic like this patient, then we after 3 months stop the ticagrelor and continue on aspirin for 1 year. Thank you for listening.